Good morning and welcome to my YouTube channel Pain Free Partha. Today's talk is about tourniquet in anesthesia, use of tourniquet in anesthesia. And a salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, and our institute, Mahatma Gandhi Medical College, Sri Balaji Vidyapeeth, Pondicherry, India. What is it actually? A tourniquet is a compressing device used to control venous and arterial circulation to an extremity for a period of time. So an extremity is an upper limb or lower limb. It controls venous and artery. It's a compressing device, that's all. Sometimes you use a tourniquet for a venous collection, phlebotomy. And this is arterial. What we use is both. From where it is derived? It is derived from the word tourner, means to turn. He was a French surgeon, Louis Petit. He described a screw-like device he strapped in the thigh of patients undergoing leg amputations to reduce blood loss. What he did was screw device is in the thigh. He did like this and decreased blood loss for patients undergoing amputation. This is how the word tourniquet was derived. So this is actually an upper limb. This was a model leg, but he did for the lower limb thighs for amputations. Turner means to turn. So from William Harvey, we know who discovered the circulation. And Morel was first used at tight band, and we know Louis Petit. And Lister used a tourniquet, and S. Marsh created a bandage, rubber bandage for tying this. So Harvey Cushing again, inflatable model. August Bayer, who administered spinal anesthesia, who invented Bayer's block. And there are a lot of modern electronic equipments now available in the market for tourniquet. This is how the Bayer originally described. To tourniquet, in between he injected IV local anesthetics, and this area was anesthetized. So Petit was the one who first screwed it and found out. And then came a Marsh bandage. We tie it to the maximum. And there is no control of pressure in a Marsh bandage. Now we have a pneumatic manual, but it is manual only, but it is pneumatic. Now you tie this and you press this, it will go like that. Now we have a lot of electronic equipments where the control itself is more of electronics. We switch touch. There is no pressure like here. There is no pressure like here. Here, many times we need to touch it. It inflates and finds out these things. What are the indications of tourniquet? When we have to put the tourniquet? Surgery, for example, distal upper limb surgeries or distal lower limb surgeries. Hand surgery without a tourniquet is like repairing a clock in an ink container, was that famous quote. So for decreasing blood loss, to clear fields, isolated limb perfusion in malignancies, intravenous regional anesthesia, Bayer's block, and we can also use for complex regional pain syndromes, sympathetic. That is what is called sympathetically maintained pain. So these are all the indications of tourniquet. Surgery trauma for decreasing blood loss, clear blood fields, and isolated limb perfusion in malignancies. IVRA or Bayer's block and IVRS sympathectomy. What are the contraindications? If you have an open fracture here, and if you have a tourniquet and IV you put, it will bleed in the fracture and it will go out. It will not reach. Blood is not likely to this. So in this contraindications, open fracture. Sickle cell disease, we all know that compressing is a problem in sickle disease. Plastic reconstructive surgery is done here, so we don't know what will happen inside. Severe hypertension, because tourniquet can cause some BP fluctuations. Compartment syndromes, compression, nerve damage, all these things. We don't have lack of equipment, and we have lack of equipment, we have lack of knowledge. People administering tourniquet also is a problem, because we need to have some problem. It might be extended to years and days, or sometimes we may get limb problems. Hours important. AV fistulas is there. Reaming, embolic on deflation, and thermal bone necrosis. Peripheral vascular disease. There is a varicose veins. A lot of varicose veins are there. That exsanguination is a problem. So sometimes if you do a tourniquet, the bleeding will be more. What are the types? Emergency, SMARSH, pneumatic, micropuscular. All these things I have told. We can have a straight cuff, or we can have a contour cuff. The limb slightly becomes a cone-like. So the cuff can also be contour with a cone like this. See here, the cuff is a cone-like, and this cuff is a round cylindrical cuff. Here it is, the diameter is slightly coming down. What are the parts of the tourniquet? There is an inflatable cuff. There is a gas source. Air is usually. Sometimes nitrogen is used. Nitrous oxide or oxygen should not be used sometimes, because oxygen can leak in and may cause flammable chances. We should have a pressure display, how much it is pressure. We should have a pressure regulator, and we should have a connecting tube. You may have pneumatic adjustments with pressure valves. You just close or open the valves. Or you can have chips, MACE microprocessor from 320 chip flight. The size is 3 to 6 inches overlap, usually described as 8 to 9 centimeters. Width is more than half the diameter. Width should be more than half the diameter. Tourniquet should be positioned on the limb at the maximum circumference. It should not go like here. Soft padding should be there, but no loose cotton like here. There should not be loose cotton. All should be cut and tied inside, tucked inside. And we should not give antibiotics after the tourniquet, because if you give in the other limb IV and tourniquet is applied to the injured limb, it will not go only. So all drugs should be given 5 to 10 minutes prior to tourniquet patients. Preoperative assessment of any contraindications. You have to discuss with the surgeon, site and size, infection or embolism. Are there any AV fistulas? All these things. Whenever we plan tourniquet, nobody sees, I don't know that. We have to discuss with surgeon, because at the time of after giving the block, no, I'm going to do tourniquet now. No, you have to discuss with the proper surgeon who is going to operate. What is the site of the size? Because the day before you have seen the size. What is the size and site I'm going to choose? Has to be perfect. And if there are any embolisms, AV fistulas, careful about cotton cast, loose fiber and loosening. Wool will smoothen the ridges of the cuff and give equal pressure. Prepare and test the equipment prior, because it may deflate after the most crucial time. In the most crucial time. So check it again before. Check it again before you administer to the patient. Exsanguination before inflation improves the quality of bloodless fluid, minimizes pain. Now you do what you do here. After some time, you remove the blood from here. After some time, you establish a tourniquet. So this is what is called. Or sometimes we can do an smash bandage here till this portion and get a good pneumatic tourniquet and then remove the smash bandage. So these are the type of exsanguinations. Exsanguine means blood. Exsanguination means remove the blood. Exsanguination of the limb means remove the blood from the limb. So otherwise, if you have full limb and inflate, there may be initially more bleeding. That's the problem. Malignancy, infection, thrombi, fracture. Now you think how you are going to move like this and do, because it is not possible. Elevation of the arm or leg for 5 minutes at 90 or 45 degrees respectively. Arm means 90 degrees, leg means 45 degrees without mechanical compression sometimes. Why to do? Less bleeding, less tourniquet pain, better fluid, less microthrombi on deflation. Some blood will be there in the circulation. We should do it rapid inflation. That is very important, because if you do ding, jing, jing like this, the veins will get blocked, restricted. Now there is a lot of time now. Arteries will, because you are doing slowly. Now you are inflated 80. Now if it goes to 120, another 1.5 to 2 minutes gone, then again from the arteries blood will collect here. So there is no use. So the inflation should be rapid. Hardly you have to leave less than 10-15 seconds before you constrict the artery in the vein. There should not be much gap. Now you see upper arm, middle thigh, arms, digits, etc. Now you can see the foam here, and it is tucked in, and the bag is exactly surrounding the vessel, and you can see this beautifully wrapped. Get the connecting tube accessible, because sometimes you put the inflation here and then the connecting tube will be here somewhere. It gets strike in between, got caught into the drapes. So when tying initially, please don't give much force. Strangulation will be useless. All ready before inflation. What is tourniquet cuff pressure? This limb occlusion pressure. What is this limb occlusion pressure? Minimum pressure required to stop the flow of arterial blood into the limb. So if you have 130 as the systolic pressure in which the arterial supply decreases, you add 40 to it. Very important. In lower limb, add 60 to LOP. Between the BP is itself high, add 60. The BP is high, add 80. Now it is 140 systolic BP, add 60, 200. If it is 190, add 80, make it into 270. For pediatric patients, adding 50 millimeters has been recommended. Now, what is to be done? If it is 140, you add 60, make it 200. If it is 110, add 40, make it as 150. You understand now? Less than, the BP is less than, limb occlusion pressure is less than 130. What is limb occlusion pressure? The pressure in which the arterial supply is gone. Now we have to find out what is the pre-op LOP, limb occlusion pressure. What is the limb occlusion time? Probably we may use 250 for upper limbs and 300 for lower limbs. Maybe 150 or 100 systolic. This is arbitrary. Systolic plus, I don't want to comment on these. 100 above and 150 above. All these things are arbitrary. 1 hour is okay. But in lower limbs, they allow 2 to 3 hours. It is better you deflate for 10 minutes and then inflate and keep it sometimes. And if you have a double tourniquet and cold extremities, dangerous. Pediatric patients, better less than 75 minutes. So ideally 1 hour. If you want to do more than that, be careful. Sometimes you deflate and inflate. Caution every half an hour the surgeon. Now we have got automatic alarms. As soon as it is inflated and keep inflated, 1 hour later, pam, 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 it will alarm. But if you are not having these things, caution the surgeon, 45 minutes is over. Now we have history. Turner, Petit, then S. Marsh, and so McKeown, all these people. Then what are the indications? Surgery, trauma, bloodless field, IVRA, IV sympathetics. We have contraindications like open fracture, sickle cells, AV fistulas. All these things are some contraindications of tourniquet. we have a peripheral vascular disease. What are the types? Previously, we have a SMART bandage. Now we have pneumatic tourniquet. Now we have all electronics. Now, what are the tourniquet related complications? Local and systemic. Normal physiological conduction block in 15 minutes. And there may be there. Nerve injuries are 0.037%. Radial nerve in upper limb, common peroneal nerve is more. Edges of the cuff, beware. If you think the edges of the cuff is close to your nerve, dangerous. Both mechanical and ischemic etiology proposed normalizes in 6 months usually. Any conduction problem, usually 6 months it becomes normal. So that is one thing. More than 1000 millimeters, very dangerous. We don't know a smart bandage. If you tie, sometimes it may be 1000 millimeters also. Orlacher et al. Combined sciatic disease. We need to disprove other causes. Yes, suggested like this. See the notes of Ranvier. They are damaged if you have tourniquet extraordinary times. Now pressure below 300, duration less than 2 hours, less likely to have permanent damage. That is why previously a smash bandage, there is no pressure control, we may allow 600 also. Muscle injury tends to be greatest beneath the tourniquet. Now there is an ischemia, there is a mechanical deformation and may persist after tourniquet deflation as a result of microvascular congestion. 3 weeks usually normalize. Post-tourniquet syndrome, there may be some weakness without anesthesia. That is very important. Sometimes you put a tourniquet and give GA. This post-tourniquet syndromes may be weakness, and we should be very careful. And the surgeon has done any problems and put the blame on the tourniquet. Swift frail limb weakness 1 to 6 weeks after high tourniquet, applied pressure gradients combined with ischemia, prolonged damage to muscles rather than it. We don't need to do anything. It will usually settle normal. Myoglobinuria have been reported with tourniquet. Only forced alkaline dialysis is needed and physiotherapy is needed. Cutaneous abrasions, blisters, even pressure necrosis, especially in children, obese, elderly, very important is this. Elderly patients, there will be wrinkles. That is where your cushion should be puckered. Direct vascular injuries are uncommon. The combination of fluid collecting under the cuff and pressure by the cuff seems to be a likely cause. Vascular injury is not combination by the pressure and the fluid collecting under the cuff. So we know double tourniquet we use for this. Bayer's block. This is the proximal tourniquet and that is the distal tourniquet. Now we go to local complications, skin abrasions, what all these things we have seen, nerve injuries. What are the systemic effects entwined in CVS? Already we have told severe malignant hypertension, beware of tourniquet. Because limb exsanguination and tourniquet inflation, if you exsanguinate and inflate, your BP is going to rise, SVR is going to rise, CVP is going to rise, heart rate is going to rise. Sometimes 300 ml will go. In lower limbs, 600 ml will go. Sometimes some surgeons will do total knee replacement both sides, 2 teams, and we have tourniquet both sides, and 800 plus 800, 1600 ml, and the patient will land up in pulmonary edema. So you can give. See, it is question of tourniquet pain causing these things many times. So sometimes ketamine may be effective. The onset is analogous to the onset of tourniquet pain. That is why the BP rises. It will happen with the GA also. Cardiac disease and elderly, be careful. Clonidine, dexmedetomidine, ketamine. Musculocutaneous nerve block has been described. What they say is if you block the musculocutaneous here, your biceps is blocked. Not only afferent is also blocked. Now the muscle ischemia, the dangerous pain is not moving towards the CNS. So musculocutaneous nerve block is supposed to be very effective in decreasing. Previously, they thought that infiltration around the axilla blocking intercostobrachial nerve. But now they say the MCN block is also effective. After deflation, this becomes hypotension, refill time and distal pulses. RS both lower limb, that's what I'm telling. If you deflate both lower limbs, they have reported RS. Anaerobic metabolites and ischemic reactive hyperemia and vasodilatations. Very important here. Now, sometimes you are doing an epidural and knee inflation, knee surgeries, total knee replacement. Now you top up an epidural. The epidural top up is going to cause BP fall in 10 minutes. And you also do a tourniquet deflation. This, it is dangerous combination. So epidural top up, if you are going to plan, give the epidural top up, wait for 15-20 minutes, adjust your hemodynamic changes, start giving, then deflating the cuff. Otherwise, deflate the cuff, wait for your epidural top ups. Usually, sometimes I give 200 ml IV bolus fast and 6 milligram of MEF on deflation in routine cases. This is about the heart. Now we go into respiratory system. EtCO2 increases. Hypercapnic venous blood is coming into the systemic circulation. No need to do anything. Little extra may be controlled ventilation, but it will settle down. Increase the EtCO2, increase the cerebral blood flow, but comes down in 10 minutes. So sometimes people used to hyperventilate before deflations. More than 67 minutes. That's why I am very careful about this 1 hour. Tourniquet is associated with hypercoagulable state. So sometimes fibrinolysis after deflation can cause bleeding. Okay, DVT no change. That is one problem. That is why people deflate before closure and see what happens. Okay, and see there is a bleeding because sometimes fibrinolysis after deflation and 30 minutes there will be bleeding. Commonest cause of bleeding extra is you don't exsanguinate the blood from the limb and start doing this tourniquet. That should be very careful. Marrow may be thinking differently. Tourniquet O's after 3 minutes. Here you can see you have put this tourniquet here and it will start to bleed from the marrow to the skin. An increase in core body temperatures occurs during the inflation because of reduced metabolic heat transfer. So inflation, temperature rise, deflation, temperature low. So already we have told anaerobic, vasodilatation, SVR decrease, BP fall. Now CO2 increase. As CO2, all these things, toxic metabolites, 30 minutes, they become normal. We have isolated the limb as administration of some other drugs cause. For example, we have done both sides, the inflation. It's not going down. Can we give propofol now? What is the dose? Can we give fentanyl now? What is the dose? Because it is not going there. But they are not well studied, but clinical relevance is less. But anyhow, antibiotics should be given before inflation to reach the site of operation. Tourniquet pain is 66%. Tissue compression, release of prostaglandins. A fibers are blocked. C fibers. NMDA agonism and central sensitization. Dull aching, discomfort. We can see tourniquet hypertension. The best thing is to remove the tourniquet. That's the best treatment for tourniquet pains. We can add clonidine, opioids, adrenaline, bicarb, etc. Local anesthetic at the edge cuff, EMLA. Intravenous ketamine, dexmet, remifentanil. Maxelf. So many treatment possibilities have been told. In intrathecal, if you add adjuvants. In local anesthetic, we can add adjuvants. Local anesthetic at the cuff. Musculocutaneous nerve block. IV ketamine. IV dexmet. Maxelf. Fentanyl. So many drugs have been used for tourniquet pain. preemptive gabapentin, conversion to GA, but the BP rises continues. Now, very important concept I want to tell again now. Now we have a tourniquet and the knee is starting operation. Now the patient starts to complain of tourniquet pain. We have started inducing GA. Pain is not there, but BP will continue to rise because the tourniquet induced hypertension will continue even if GA. The answer is you have to deflate and reinflate or deflate and remove. That is the treatment for tourniquet pain and hypertension. Postoperative tourniquet pain even for 3 days. And they have told preoperative EMLA cream. Nerve ischemia, muscle damage, reperfusion, so many things. Lignocaine patches. Is it possible? But sometimes what they say is, if you do tourniquet and TKR, the quadriceps function is depressed. But if you can do this, there are certain things which say that certain articles, tourniquet does not affect functional outcomes. They have put tourniquet release cardiac arrest, especially if you do tourniquet, both lower limbs. Postoperative pain, edema, infection increased. If you do with tourniquet, tibia, plates and nails. Ream with tourniquet, bone necrosis. Femur fracture was treated by intramedullary nail. Tourniquet use for the other limb might increase pulmonary morbidity. So fentanyl medas will come after deflation and sedate. All these things are other effects of, for example, if you ream and bone necrosis, or sometimes they say the healing is not as that good. There is a pressure inside the joint. That is what they say. If you do a tourniquet, the joint fluid. There are use of personalized scalp in pediatric cuffs for chemotherapy. There are a lot of misuses, inflation, pressure, and time. How many lumps? Very important. Fast inflation. The pressure should be LOP plus 40. Time should be 1 hour. How many limbs we are inflating? This should be in our mind, anesthetist mind. So history we know, types we know, pressure and times, systemic changes, local changes, tourniquet pain, extreme vigilance during deflation. Very important. Surgery is over, many people will go. Deflation, deflation, deflation. Thank you all. Visit me at painfreepartha.com for slides and subscribe my channel YouTube for Pain Free Partha for more videos. Thank you.